Hello, everybody. My name is Josep Malvehy, and I will try to give you my thoughts about benefits and risk of AI in Telederm. These are my conflicts of interest, my funding collaborations. This will be a bit better in terms of reading, but they won't affect the content of my lecture in the end. And I'm also co-chair of the task force of the AIDB and artificial intelligence. I'm participating also in the task force for Toledar with intention to promote the use of or the introduction of AI and the knowledge among the community of dermatologists and the community of patients in the end of these technologies. Also, I'm involved in the IC group of artificial intelligence working group, led by Veronica Rottenberg. And just to mention a few questions, and I want to start with the discussion that all you know about benefits, pros and cons of e-health in general, where we are involved today, with the promise of improving education awareness, access to dermatologists for diagnosis and treatment support, etc., and probably reducing cost, and with the cons of the possibility that we can create a new form of exclusion for some people that have no access to e-health, and this also includes AI and telederm in medicine. It can alter the practice of what we want to have in our relationship with patients, and finally privacy, data protection, and legal issues. But we are involved in this revolution, and this affects of all these levels, even in research and health technologies development, also in healthcare system, of course, where we are involved in the introduction of these new technologies, and also in the population with many challenges and opportunities in general. When I try to assess the potential benefits and risk of AI and telealarm, clearly it's very similar of what is assessed or considered for mobile health. Of course, potential benefits can have that can be at reducing healthcare costs, improving quality of care, increasing the access of patients to dermatology care. In the end, maybe they can even empower patients or doctors with the use of these technologies, and in the end, this is a change in the context of healthcare as we knew before. Um, and and and, and this can be very promising, but at the same time we know all the risks, and this is that we need a good framework. Sometimes it's not uh, there to help companies and healthcare in the end to introduce these new technologies. We have professional hackers, professionals that are lost with all this new knowledge, and they need support for that. We know that we have a lack of standardization. We have inequalities in access to this in different countries and for different populations, etc., etc. Uh, and this is a reality. We started with the man against machine with different papers in skin cancer with these excellent results of algorithms compared to dermatologists in reader studies in silico. Today, it's more about human and machine collaboration, but at that time was man against machine. And today we have some commercially available devices in our clinics in dermatology using algorithms that the companies claim that are only for research, but my colleagues are using this for taking decisions. I can tell you, they tell me, oh, the machine was saying that was suspicious or what a risky lesions, and I decided to excise the lesion because of this or that, in 2D and 3D and different situations. So this is the reality we're living. And in Telederm, yes, we can apply artificial intelligence in with the promise of improving recommendation issues, education, risk monitoring, etc., in different forms of telederm, from direct to consumer telederm, primary telederm, secondary telederm, or tertiary telederm. But I have to stress and that in here we have different scenarios. uh, the users and the patients are different, and probably the complexity of the consultations are different. So, and this has to be understood in the assessment of these new technologies in Telederm as well. Are we ready for the introduction of AI in teledermatology? Well, let's have a look on different reviews. This is a paper recently published with the collaboration of different authors, including myself, where it was a review of those papers with reading studies by dermatologists comparing the AI algorithm for skin cancer, and this was assessing clinical papers with clinical images or histopathological, most of them with dermatoscopic images, and they are very good at the classification of skin cancer. But they are using highly artificial settings, and this was the conclusion of the paper. And these may not represent the full range of patient populations and melanoma subtypes, just to mention a situation. When we have some of these licensed apps in Europe for the assessment of individual lesions by consumer uh, direct to consumer solutions in the market. In this study in the National Skin Cancer Day, dermatologists were using these apps with patients during this campaign, and the results were that many of the benign lesions were rated as suspicious, and vice versa, with some concerns about the introduction of this in the market, because this may happen to be that many patients could be anxious with this assessment in the end. We have also the situation that some less represented forms of a melanoma, like a melanotic melanoma, or very high risk potential cancers like Merkel cell, are clearly not being assessed with good accuracy with these models, because basically we cannot train these algorithms with these tumors because they are not well represented in our databases with meat matches. Probably this is a challenge, and this is having a real impact in in the end. Or when in the ISIC challenge in 2019, we put together with the test set, in the test set, out of distribution images of different tumors or clinical dermatological conditions, and then the accuracy was decreasing very significantly because of this. Clearly, algorithms cannot recognize what they don't know to recognize, and this is different of what happens with humans, where when you know what it is, you know that you don't know what it is, and you don't try to classify this. But this is a reality, and in the end, this is the real life that we have. We have the limitations of artificial intelligence. Probably you all know about these discussions, but the black box nature, it's difficult for users of a diagnostic tool to use something that we don't know how it works. We have potential algorithm biases that have to be assessed properly in these studies before the introduction of these tools. And I have to say that some of the publications about skin cancer and other situations may have potential biases that were not properly assessed in the methodology. We have the underrepresentation of ethnicities or less frequent conditions that may be relevant in terms of overall use of these technologies in the general practice. And finally, regulatory and liability issues. In skin cancer, we know that we have the risk of false diagnosis, and this is not a banal issue, even if we have good performance or good accuracy for very clear clinical scenarios like pigmented skin lesions. Uh, this is a risk. We need good prospective studies. Some of them were already published, and we will have probably very soon some others. But we need to understand in particular scenarios well, with a very good definition of the clinical application of these tools in Telederm with artificial intelligence, to understand the clinical benefit and true performance. And finally, we have the challenge of the introduction with the new regulatory environment. These technologies in the future. Well, these are potential harms, and this may affect patients, clinicians, and health system, and we have to be very aware of this. Clearly, in any new technology, we have to be aware of these risks, even if they are licensed and they are used today eh, by by uh, by our patients because they are in the market. We need to understand better of this risk, and this is very essential. Imagine a situation where a doctor has a contradictory conclusion of one referral by Telederm uh, compared to the algorithm, and of course the final responsible for the decision is the doctor. But in the end, if he or she is wrong, it could happen that in the end some liability could appear in the future, and this may affect the final decision of doctors about this. So if the software is saying, "Hey, it's a risky lesion," even if I think, wow, the differential diagnosis is far from being risky lesions uh, in my main options, I will excise the lesion, to be in the safe side. That can be a situation in the future. We have this clearly collaboration that it's a reality, and for that we need studies in clinical practice. This is not a prospective trial, but here the authors were putting together a number of images sent by patients with devices using uh, telederm and dermoscopy with a good sensitivity of melanocytic and non-melanocytic skin cancer with a good specificity, just with a statement that this can be a reality, and I think it will be a reality for the triage of lesions. We have other studies like this prospective study in the UK with 7 hospitals with a good accuracy for skin cancer that can reduce the number of referrals to dermatologists and promote an efficient triage system in the anintoloderm in the future. This other paper with in general dermatology assessing with clinical images a good number of clinical conditions. In dermatology, we have probably many more, but they were introducing more than 130 classes with an accuracy that it's not a spectacular, but can be in general acceptable compared to GPs. And well, this is interesting because they can distinguish malignant prediction that can be more accurate compared to a strictly classification by diagnosis, or they can even promote suggestion of therapies in situations like that I mentioned before, like eczema versus infection diseases, and avoiding the use of corticosteroids that is very frequently an issue in the end. We have this paper interesting because they were introducing metadata, and they proved that metadata can improve the accuracy of the algorithms. They use multiple images of these general dermatological conditions that makes a difference as well. And this was having for these 26 common skin conditions a good results. Uh, of course, this is not a prospective clinical trial. One a critic of all this is that we have no good representation of every of the ethnicities in these studies. And this is a paper coming from India, where they were also validating the algorithms for telederm in terms of common dermatosis. Not so much in skin cancer. In India, this is not so frequent compared to Europe, but for many common dermatological conditions, and this can improve the therapy or the final quality of the dermatological care of patients with the introduction of these in the future in telederm. In some particular conditions, the algorithms can be better than doctors in determining if an onychotrophy dystrophia has to be treated with antifungal drugs or not. And this is a big issue in general practice. Or in this prospective trial where they were very ambitious, they were assessing as 174 multi-class algorithm in real life telemedicine setting by patients sending pictures with the cellulars to untrained dermatologists for AI with yeah uh, an accuracy that was about 40% with out of distribution classes and 47 uh, 0.6% with only in class distribution. This is interesting because they were assessing in Sao Paulo, and these people were and they will participate in this congress. This is will be very interesting. They were assessing the algorithms in Telederm with intention to understand the prioritization of Telederm in terms of classification of different consultations, and also if the patient was considered for face-to-face dermatological assessment or direct biopsy compared to follow-up with teledermatology. And they achieved with this simplified classification test a good accuracy and similar of what we had in by dermatologists. And finally, this other paper, where they tried to introduce the artificial intelligence to improve the accuracy of practitioners, general practitioners, and nurses in dermatology for the assessment of general dermatology situations, where they improve in 10% the accuracy of their conclusions. Compared to the reference that was the dermatological assessment of these consultations. Well, this may have an impact in the healthcare system, even with this limited 10% of benefit. And my final conclusion is that yes, all this is coming, but we have a last barrier for the new companies and the community of end users to have these new tools in their practice. And this is the regulation that it's not anymore possible to have class 1 certified AI algorithms for classification of skin tumors or skin lesions. That was the past. And now in Europe, it will be required at least class 2A certification that needs now needs an clinical evaluation and in the end a process that can take even 1 year, and with an extra cost that is not a minor issue for these new small companies trying to evolve in this. And my also this may happen to be that this can slow the process for the introduction and the certification of new devices. And in digital health, is not the same that drugs or pharmacy or other medical devices that can take years to have this certification. In e-health, everything is moving so fast that we need a new environment for this. My conclusions is that yes, this is now ready to be tested in practice, but we need to determine how robust are these technologies before we introduce them in the clinical practice. Because what we want is to have safe, effective, and accessible deep learning technology in the future for our patients. And of course, we are together in this effort with companies, academic, and practitioners for the benefit of the healthcare in dermatology in the future. This is my team in Barcelona. I want to thank them for this work, and thank you so much for your attention.